Thanks very much, Jordy. This has been a wonderful day. We're sorry we can't stay for tomorrow because we're sure we're going to miss something we would have loved.
Anyway, you're right. It has been a wonderful day, and I enjoyed hearing all these intelligent people discuss things that we care very much about. We'll start with an apologia. We are physicians. We have spent the past 18 years studying medical professionalism, and we wouldn't presume to be experts on professionalism or the social contract of other healthcare professions. So we suggest that there are similarities and differences, but the underlying principles of all healthcare social contracts are the same. So why are we discussing professionalism? Why now? And why the social contract? There's general agreement that all professions in society, including medicine, are under threat. That the questioning society in the 60s questioned all authority figures, and we didn't miss out on that. And what medicine has done in response to this is to try and be sure that all its graduates and trainees and practitioners understand what professionalism is, what their obligations are, and that they have acquired a professional identity. Now, the concept of the social contract actually helps in teaching and learning of professionalism. Actually, our students feel empowered. Today's students need to be told the purpose and meaning of activities that we require of them. They don't respond to thou shalt. They want to know why they are doing something. And the social contract provides the why. It describes the reciprocal nature of medicine's relationship with society. It is a logical basis for the obligations that we have and the attributes. It emphasizes the consequences if either party fails to meet the legitimate expectations of the others. And our students feel empowered because they don't feel that they're going into a system they may be able to influence as opposed to being thou shalt.
Now, no, you're still on.
I'm still on?
Yeah.
Okay, nobody is satisfied. Society is, to quote Dunning, a better informed community is asking for accountability, transparency, and sound professional standards. Medicine, on its part, feels that its autonomy, and we had quite a discussion of that this morning, is severely restricted by budgets, bureaucracy, guidelines, and peer review. So nobody's satisfied. The result is that, of course, our relationship with society is being looked at, is under intense scrutiny, and most people in the literature call this a social contract, a term that has actually been around for 300 years. And the basis of it is really reciprocal rights and obligations. In medicine, the concept is frequently invoked, but nobody ever really analyzes it.
So we'll see if we can analyze it. What is a social contract? Well, I think certainly there are people in the room that know a lot more than us, particularly if they've studied philosophy. The concept came from Hobbes and Locke and Rousseau and Montesquieu and on and on and on. Originally invoked to explain the relationship between citizens and the state at a time of hereditary monarchs. Well, that doesn't work very well anymore. But the concept has evolved over time, and it is still used to describe the organization of contemporary society. And we could talk about John Rawls, who was a contractualist. Norman Daniels carries on that tradition. So it's still a very relevant concept, and it stresses, as Sylvia said, mutual privileges and obligations, something Matt talked about this morning. So we're big on definitions. Anybody who's heard us would know we always define everything. The Oxford Dictionary of Philosophy defines a social contract as a basis for legitimating legal and political power in the idea of a contract. And of course, this is why we think this is important, that compact and other words, covenants, don't work because they don't have the same implications. Contracts are things that create obligations, hence if we can view society as organized as if a contract had been formed between the citizen and the sovereign power, this will ground the nature of the obligations each to the other. So that's what we use, and we, by the way, use it with our students and residents. Now, how do we transpose this big concept into healthcare? Donaldson and Dunphy, actually at the Harvard Business School, had a really interesting article where they talked about macro and micro social contracts. The macro contract includes all of the essential services required by a population, according to them. Micro contracts, and they were, by the way, not talking about healthcare, includes individual essential services. But the micro contracts have to conform to the moral boundaries laid down by the macro contract. And so this is how we would suggest. We would say that healthcare professions have micro contracts. And I think they all have some differences in their micro contracts with very substantial core of shared elements, I guess. And just to sort of have a little case study, because this is an international conference, we share a continent with most of you people in this room. The macro social contract in Canada and the United States, and I would suggest in Australia and in India and so forth and so on, have substantial differences. In the United States, individualism and individual performance is very, very important, stressed. Whereas in Canada, we assume collective responsibility for a whole lot of things. So our social safety net, for example, is very different from the social safety net you have, and that's true of most other countries as well. Now, that macro contract influences, we believe, the micro contract in healthcare. Healthcare is a right in Canada and many countries, whereas down here I think the official legal definition is public good the last time I looked. I don't think it's been changed recently. So that's our concept of macro versus micro, and so we will be describing the social contract in those terms. Now, the social contract in healthcare hinges on professionalism. We didn't make this up. Matter of fact, we didn't make up hardly any of this. It's drawn from different disciplines and so forth. This has appeared in the sociology literature for years. It's Fred Hafferty's said it lots of times. It serves as the basis of the expectation of medicine and society. We must remember, and we're going to emphasize this, that under this contract, society has legitimate expectations, but so does medicine and so do other healthcare professions. It's constantly being renegotiated as society and medicine evolve. Social contract today is very different from the social contract of the 1930s. Look at divorces, abortions, all kinds of things. Professionalism has got to evolve as that happens. So if we look at the historical contract, what Fred called nostalgic professionalism in a couple of his articles, solo practitioner, patient payer, accountable to the patient, and there's where we think the individual covenant maybe comes in, because it was isn't a contractual relationship. Minimal accountability to society. When Sylvia and I graduated from medical school eons ago, we wouldn't have talked about accountability to society. Our accountability was to patients. Lots of opportunities to demonstrate altruism by taking care of the po folk who couldn't afford health care and charging a little extra to others. And of course, a very high level of trust. Now that's nostalgic professionalism. It isn't the professionalism of today, but it persists in our self-image, and also we would suggest persists in the image of lots of the patients. Often this is what they yearn for, sort of the good old days, which weren't so good. So the contract has evolved, and Matt showed you a little bit about that. Prior to 1960, as Elliot Friedson pointed out correctly, he took a snapshot of medicine at the time, and that snapshot shows that we were dominant. We wouldn't have been talking about team care in those days, I promise you. Till 1960 to the present, the state and the corporate sector have taken over, and they are dominant in, the state is dominant in our society. The corporate sector here, I would suggest, always, as Friedson and Matt have said, with some element of professionalism in them. So the new contract has higher levels of accountability and consequently diminished autonomy. The more accountable you are, the less autonomous you are. Diminished levels of trust, although individual physician trust is held pretty well. Increased patient autonomy, increased demands for transparency in what we do, increased financial rewards, which lead to increased conflicts of interest, and of course, increased team health care. And as we will come to later, altered expectations of both society and the professions. If you look back at the literature, and when we present you with expectations and things like that, as much as possible they're based on the literature, you'll see a big change. So the threats to medicine's professionalism, we would suggest now, and I think this is true of other professions, come from two sources. The first is from within the profession, from our failures to adequately control those areas under our direct jurisdiction. And we're moving to try and make that better, but that's certainly a very significant threat. The sociologists correctly pointed out our failures. But there are also external threats, and we've talked about this in virtually every meeting we go to on professionalism. Those areas that are beyond our control, essentially the healthcare systems and the cultures into which our graduates must emerge and practice. Somehow we've got to figure out how to negotiate systems that actually support the role of the healer and the professional. We'll come back to that. Now, professional status is really important to all healthcare professions. Every grandmother wants their grandson or daughter to be a professional. It confers prestige and respect. We are generally trusted. We have varying degrees of autonomy in practice. We have the privilege of self-regulation, things that are changing around the world, but it's still largely there. And of course, we are rewarded. There aren't very many people whose children can't buy shoes if they are members of professions. But we must remember that if those were the only reasons to preserve professionalism, that it would be selfish and it wouldn't survive. We heard a little bit from Matt this morning that the 1960s till the 1990s exhibited high degrees of criticism of professions. So going back to George Bernard Shaw, they are a conspiracy against the laity. As the state and the corporate sector became so prominent and dominant, the sociologists, including Fred, Bill Sullivan, and Elliot Friedson, went back to professionalism as the least worst way of organizing healthcare. The reason being, and we're quoting Bill Sullivan, neither economic incentives nor technology nor administrative control has proved an effective surrogate for the commitment to integrity evoked in the ideal of professionalism. That's why we're all talking about professionalism, because we're talking about professional identity too. The actions come from within. They're not imposed by a regulatory system.
So what is medical, and put in healthcare professionalism? When we teach, we point out, and this is true of all healthcare professionals, that there are two roles. You are a healer and you are a professional. Now, you are the same thing. You don't get up at 8 in the morning and decide you'll be a professional, and at 11 you turn into a healer. You are all, to some extent, at all times. But to understand them, we think it's easier if you analyze them separately. And part of that goes back, are you going to go? Yes. To the different origins. If you look at the healer, that goes back before written history. There have always been shamans and medical men and women. Is that to me? In societies, and healers have always had an important role. We date ours usually to Aesculapius and Hippocrates, Maimonides. Every culture, if you look, has its sort of leader in the healer role. They didn't do very much. They provided great comfort and so forth until science came along, and technology, and then we were able often to cure, not always. And this leads us to the present. Now, the professions are younger. They arose in the Middle Ages, the learned professions of law, medicine, clergy, and at that time, the military, were established then. But they didn't serve an elite of society, and there was some question of whether you were wiser to go to a physician at that time, think of George III, or not. It wasn't until science again came, and in the time of the Industrial Revolution, which gave society enough money to actually buy health care, that the government started looking around and decided that they needed to control this, and by legislation, they gave us our monopoly for each of the professions in healthcare. And because science was so important, our linkage to universities became very important too. And this leads us to the present. The two things that link are the codes of ethics, which actually describe the behavior of both the healer and the professional, and science, which empower both. So when you read about professionalism in the literature, and when people talk about it, usually includes both roles. It's just for the teaching purposes we think it should be. Now, the other thing is if you look at the literature, what attributes are expected of a healer and a physician. If you look on the left-hand side, the healer has caring and compassion, insight into how both the patient feels and they feel towards the patient, openness to different people, respect for the healing function. We don't heal, the patient heals, we help them. Respect for patient's dignity and autonomy, and we advocate for the patient to get them through the system, and very importantly, presence. We are there and we accompany the patient through their disease. Now, on the right-hand side are things that aren't in the Hippocratic Oath and not in the healer tradition. That's autonomy, ever degrees of it. The fact that we set our own rules and regulations for entry into the profession, for exit from it, if you will, for teaching. And this is carried out by our physician-led associations and institutions. We more recently, in the past 50 years, have gotten a responsibility to society. And of course, teamwork, as we have been discussing, is increasingly important in all healthcare. In the middle are the very important ones that are shared. Competence, obviously, in neon lights. The commitment to help the patient. Confidentiality. Altruism, that we put the patient's needs above those of our own. That we are trustworthy, and that means we have integrity, honesty, we follow the codes of ethics, that there's morality and ethical behavior at all times, not just in our practice, but that is expected of us at all time, and we, of course, are responsible to our profession. Now, the reason we do that is because if you change physician to lawyer, and if you change healer to adjudicator of disputes, the right-hand circle stays the same. The left-hand circle attributes will change. Now, the primary role is that of the healer. That's what we all are. A healthcare professional is a healer. And we have got a definition of a profession that we use for teaching. We can't remember it, so I have to read it. But it includes all the various things that are necessary for a student and for us to know.
And if I could just interject something with reference to this morning. We would suggest that if you're going to talk about professionals and professionalism, that you go to the word profession. You started with profess, but the profession is in between. And because if you're talking about what a professional is, it should, professionals are people who demonstrate the behaviors expected of the member of the profession. So that's why we chose to go to profession rather than other words.
So I will now read this thing that I can't remember. It is an occupation whose core element is work based on the mastery of a complex body of knowledge and skills, right out of the Oxford English Dictionary. It is a vocation in which knowledge of some department of science or learning or the practice of an art founded upon it is used in the service to others. That's the important part. Its members are governed by codes of ethics and profess a commitment to competence, integrity, and morality, altruism, and the promotion of the public good within their domain. These commitments are the basis of the social contract between a profession and society, which in return grants the profession a monopoly over practice, the privilege of self-regulation. Professions and their members are accountable to those served, to their colleagues, and to society. Now, this is the definition of a profession that fits law, fits engineering, et cetera, et cetera. Now, what is universal is the healer. For us, the health professions, the universality, and I think when you go around the world and sit down and talk with other physicians in healthcare, you feel right at home, you understand each other because you're healers. But the professionalism will vary between countries and their cultures, and this will depend on their social contract.
So why the social contract? Let's come back to that. We would suggest that it provides a dialogue that must take place between medicine and society. And I think when we look at what happens down here, it's that lack of a dialogue that we all kind of decry. It supplies a rationale for the presence of our professional obligations, and also it implies consequences if medicine or society fail to meet each other's expectations. Rudolf Klein, a neat sociologist in the UK who wrote about the NHS several times, called it a bargain. Medicine is given prestige, autonomy, privilege of self-regulation, and rewards on the understanding that it will be altruistic, self-regulate well, be trustworthy, and address the concerns of society. We thought that was much too simple, so we've done our best to make it more complex for everybody. The social contract is interesting. It's a mix of the written and the unwritten. I think everybody understands this. Licensing law, healthcare legislation, codes of ethics, all of these are public documents and imply often legal obligations on us. But there are moral obligations. That's why that quote by Bill Sullivan is so important. You can't legislate care. You can't legislate compassion or altruism. It has to be demonstrated. Either has to come because you're pretending or because you really believe that way. And of course, as we said, there are universal, there are things that are universal, but there are big local differences in countries, and it's constantly being renegotiated. So who are the parties to the contract? Well, I guess that's why I said we're going to make it more complicated. Everybody talks about medicine and society having a contract. Well, it isn't nearly that simple. We in the medical profession are not monolithic. We've got individual physicians who have a variety of beliefs from left wing to right wing and wonky. And we've got institutions that are chosen to represent us. We don't always, I don't certainly always agree with what my orthopedic associations are doing, or the Canadian Medical Association. And I'm sure that if I substituted another association down here, I'd get some understanding. But there's a dynamic between individual physicians and their institutions, and eventually we get a stance on what we would like the social contract to look like. There's certainly never going to be unanimity. Now, society is even more complex, particularly in democratic societies, where we consist of citizens and those chosen to govern us. Patients and the general public are a bit like the medical profession. Individual patients often have wishes and desires that will not be acceptable to the general public. But again, particularly in countries that have national health insurance, about every 4 or 5 years they get to vote on what they think of the social contract, frankly. So they end up with some kind of consensus. Now, governments are even more complex. Politicians, civil servants, and to an increasing degree managers in the field, all of whom have their vested interests and their desires from this social contract. Now, the relationship between the two major elements of society is political. As I said, every 4 or 5 years you get to vote. Half-life of a Minister of Health in Canada is pretty short because it's a very contentious area and it's pretty hard to do it right. The important thing for professionalism is that the expectations and obligations of both sides are drawn from this contract, and that professionalism has got to guide our conduct as we negotiate this contract and as we perform in our day-to-day life. Now, there are some things that aren't on that slide. This is drawn from Rosen and Dewar in the UK, what they call mediators of the social contract. We've changed it a little bit. Certainly the nature of the healthcare system is enormous. I mean, just look at the differences in your country and ours. The regulatory framework has a lot to do with the social contract. Look at the changes in the UK following the Bristol cases, where from a legal point of view, the medical profession is no longer self-regulating. The commercial sector, other stakeholders, and the media all have both some input and an influence on how the social contract is.
So what are the expectations of medicine and society? And this we have drawn from the literature and sort of put together. In the first place, society expects us to be healers. That's what health professionals are. They expect that when they go to a health professional, they're competent, that they know what they're doing and are good, that they have access to care when they need it, and that's sometimes a problem. That they will have, that the healthcare professional that they see is going to have their interests first above their own personal, when they won't be doing whatever they recommend for personal gain. The very important things that make a health professional trustworthy: morality, integrity, honesty, and codes of ethics. And I think many of our students and professionals forget that codes of ethics are public documents, and the public actually reads them and expects them. And so we try and encourage them to read them too. They expect accountability and transparency, respect for the patient. They want their dignity and their autonomy respected. They are looked to for a source of objective advice. Think of the epidemics of bioterrorism and so forth. Who do they go to? It's the health professions. And the sociologists will tell you that unless they promote the public good, there isn't an excuse for a profession at all. Now, seeing as this is an as-if contract, we have our expectations also. We expect to be trusted. We know that if a patient doesn't trust you, you can't really help them that much. So we expect trust, and we expect to have enough autonomy to make the decisions in the best interests of the patient without having someone else tell us what we have to do in an individual case. Follow guidelines, follow best practices, but the individual patient sometimes doesn't fit. Self-regulation, we do set the rules for the various aspects of our professions, as I mentioned before. We all want a healthcare system that is value-laden, adequately funded, and reasonable freedom. And actually, the public wants that also. There is a role in public policy. We have had some of our current shortages in Canada of health professionals are because the people making the policy didn't listen, and they cut class size and had some buyout principles, and we've been suffering under this for 10 years. So we do want a role in public policy, and we want to be listened to. We expect both the society and the individual patient to accept some responsibility for their health. You know, if they don't stop smoking, they're probably going to get some dreadful disease. We expect our monopoly through licensure to continue. And increasingly, the modern generation expects a reasonable lifestyle, which they have to balance with altruism. And of course, we expect rewards. I'm going to have to let you go.
Both financial and non-financial. And the literature is interesting because it emphasizes the importance of the non-financial rewards to many professionals. So there are consequences when these expectations aren't met. We call them breaches of the contract. That may be a little strong.
You go ahead.
Okay. If medicine fails to meet societal expectations, it's pretty clear. The result is a change in our social contract. There will be less public trust in that contract, less trust in us if we fail to do what we were going to say we were going to do. Matt alluded to that this morning. We will have less influence on public policy, and I think we've seen that around the world. Whereas 50 years ago, medicine had enormous impact on public policy, we're regarded as being self-interested, so it's less. Increased external regulation, decreased self-regulation, and decreased autonomy. Let's look at a Harvard Business School case study. The United Kingdom, pediatric cardiac surgery carried out in Bristol, mortality rates 2 to 3 times the national average. Everybody knew it. The departments, the anesthetists, the surgeons, the Royal College of Surgeons, the local health authority, the hospital. Nobody did anything till a whistleblower came, and then it hit the fan. 2 or 3 royal commissions later, there have been changes in the regulatory, in the mandate of the General Medical Council. General Medical Council is now made up, its board is made up of a majority of lay public, so the medical profession technically is no longer self-regulating, and they hived off discipline to another body, and the membership of the General Medical Council, rather than being elected by the medical profession, is appointed by the Appointments Commission, which is a UK government body. Huge consequences to the medical profession failing to meet legitimate public expectations in a domain which was under its direct jurisdiction. And it's happening around the world. We've had changes in our regulatory laws in Canada, which is withdrawing some of the autonomy and power of our licensing bodies. Now, if If society fails to meet our expectations, it's a little more complex, and there actually isn't any direct literature that we're aware of. But we would suggest that it's a bipolar disorder for the medical profession and probably other health depressants. When things are not going well, which in our little jurisdiction these days is often, we have decreased trust in the system, the contract. We cease cooperating, we withdraw. Going to work becomes a job rather than a calling, and there's probably less job satisfaction. On the other hand, there have been lots of very good days in our world where we're optimistic. We think we can make things better. We can treat patients better. We get involved with our community, with our associations, with other stakeholders. We negotiate, and we would suggest that there's probably increased job satisfaction. So let's look at the examples. Canada 2013, we had under OECD rules in the 90s the healthcare system that was le plus performant, according to the OECD, the best performing. Decreased funding, decreased personnel, decreased personal freedom has disillusioned the medical profession. We're not happy campers. We're getting a little better, but there certainly is less trust in the system. There's been a major change in the social contract, and that change has altered our behavior. Down here, allow an outside observer to state that the market-oriented system forces you to become entrepreneurs in a competitive marketplace. Competition diminishes collegiality, which is a very important part of the profession's ability to self-regulate. Uninsured has posed serious moral dilemmas to most American physicians, and you're still going to have some. Increased accountability has led to decreased autonomy. Big change. Got to remember, we graduated from medical school in 1955. We've seen all of these changes. So there's decreased trust in the system. Your behavior has been altered. There's uncertainty. So what should...
I'll give it a go. What should medicine do? Because these things are going to stay around. It isn't going to, they aren't going to go away. It's because society is changing, and so are we. So medicine has got to look at those things that we have control over and deal with them, and we've got to learn how to negotiate those things we cannot control so that we can negotiate a social contract or a healthcare system, however you want to put it, that supports the role that we have, that of the healer. So what within our control can we address? First, we need to understand what professionalism is and what are our obligations to society. And this is done by teaching professionalism and the social contract, foster the development of the professional identity of medical students, residents, faculty too, and practitioners. We have to look at where we've failed and look at the perception that we are not as altruistic as we were, partly because of the lifestyle balance with altruism, partly because of the conflicts of interest with financial gain, which we've managed badly. Better now than we did, but still they're there. And collectively, sometimes our associations act more like unions than they do, and defend their members rather than the public. And the lack of attention to the distribution of resources, a lack of social justice. So we now, of course, have to also negotiate to address the external stresses. And as we have mentioned before, that this takes a single coordinated voice and somebody to negotiate with. With healthcare systems, have a government with whom is our negotiating table, and we have had to develop a single negotiating coordinated voice. We have to recognize that we're not the only ones in the healthcare system. There are multiple stakeholders, including some of the commercial aspects, and we're no longer dominant. But society needs a healer, and we will be at the table. The negotiations have to preserve trust, and they have to satisfy both sides. It can't be a one-sided deal. And they're not symmetrical. Society determines the nature of our social contract and therefore of our professionalism. And because they need the healer, we will be there.
So, how do we negotiate? It's very interesting. We're enormously grateful to Norman Daniels, who published Just Health in 2008, and he's got a little section on social negotiations, which we think resonates. He defines it as various forms of interaction between professional organizations and broader political institutions. It may lead to specific legal arrangements, or there may be broader understandings that emerge from public debate about specific issues. And if we could sort of look for examples, the legal arrangements are there all around us. The negotiations that lead to the institution of a national health plan or a modification of that plan. We've gone through several iterations in Canada. You've had 2 or 3 attempts, but Medicare, Medicaid were those types of negotiations, as was your recent Healthcare Reform Act. On the other hand, there are things that are more subtle. There are negotiations taking place every single day that are influencing the social contract. We've sort of thought, again, another obvious example is the evolution of the doctor-patient relationship over the last 30 or 40 years, from a paternalistic doctor-patient relationship to one which stresses patient autonomy. That took place in a decentralized way. That was a discourse between the public and including an old magazine called The Reporter and the Saturday Review of Literature and a whole bunch of people who were Norman Cousins. I mean, it was a wonderful time, but it's social negotiations. They take place constantly in every healthcare system, and they really are the mechanism through which we affect change in institutions, roles, and standards. And of course, we in the healthcare professions, and this is something where we all are together. In fact, I'm not sure that nursing doesn't have more social capital than the medical profession does these days. We draw on that social capital to challenging existing rules and to try and to find new systems. I would suggest to you that you're trying to do that in this workshop pretty well full time. Sorry. So what should we do? We can't change the social contract all by ourselves. It's essentially the healthcare system. Jordy will remember this. The public and medicine have similar expectations, and we should form an alliance to negotiate a social contract and we should be very specific. We're not talking about dollars and cents or things like that. We want the values of the healer and the professional preserved in a new healthcare system. And about 10 years ago, following an ABIM meeting, Jordy and Sylvia and a gentleman from the UK published something to that effect.
Yeah. So just to sum up, we are almost through. Medicine's profession is under threat, and that's the healthcare professions, I think, as a whole, and that it is important to both us and to society that we can preserve it. It serves as the basis of our social contract, and when you think about the social contract, it's the basis for the discussions we're going to have with society and a rationale for our obligations. And we'd like to end with a quote from Václav Havel, who was the head of thing, who said, "The culture of healing may be less visible aspect of life, yet it is perhaps the most important indicator of the humanity of any society." So that's what we're here for. Thank you.